more or less.
I asked Dr. Barrett twice.
In and out.
Oh, no, you don't have.
Will it come back on its own? Yep, there it comes.
There was no testing.
We're going to cover hearing, vision, cancer, and functional fitness. And I want to introduce you to two guys. This is was my CEO. He's currently CEO of Switch Healthcare. He funds Switch Healthcare out of Seattle. And for 3.5 years, I worked with him, and I did basically research on 18 chronic conditions. And a lot of the research I did there, I brought over to this course. So we can thank Carl Myers for doing that. And Philip Walling, who's the Chief Operating Officer. He was an artist and a helicopter executive before Carl hired him away to work with us. And he was a helicopter executive, and we went to ask him what his worst day was, and he said, well, he was in charge of the largest helicopter operation in the Northwest, training helicopter pilots, and they ran around helicopters. And one day one of his helicopters went down with a very prominent Chinese executive and one of the leading politicians from the city of Seattle, and they died. He said, that's a bad day. So, I appreciate what they do. They're still working up there. I'm sort of in the bullpen waiting for them to call me up again. I'm literally their emeritus professor. So today we're going to work back on our list. We're going to tackle cancer, and we're going to tackle vision and hearing. Next week we'll hit the respiratory and lung stuff, and also so the respiratory stuff will be hit next week, and then we'll pick up some things like osteoporosis, but we'll try and pull it all together, mainly focus on behavioral stuff and how you guys can deal with the challenges out there once you have all this knowledge that's been pumped into you, like taking a drink of water out of a fire hose. I apologize for that. So let's talk about hearing. My industry has a name for people who are older. The average age in this class, by the way, is 72 years, 2 months. I went through the, assuming my Excel spreadsheet talents are okay. Dr. Greger shared his hearing file with me, and this is a study that was done on the Maybam tribe, which is in sort of East Sudan, and they don't have any noise exposure. And what you see here is the women on the left and the men on the right. And these are the Maybam. This is how much their hearing went down. This is what a matched group from Wisconsin did.
Wow.
So what this shows basically is it isn't just aging, because they didn't have hearing problems. Noise is definitely a problem. You want to stay away. I always worry about all these people running along the bike trail with these, how loud they are or something like that. So the theory at this point is probably small vessel disease, like arterial disease, but the small vessels. And so you basically want to avoid noise, and you want to eat for arterial health, and we covered that in second class. Can't do much about this one here. I was talking to Lee earlier, who's a little over the age of 90, and we don't know if you're the oldest one in the class, but you're certainly up there in the running. Not much you can do about that. Hi. You talked to the A team just showed up. So at any rate, when I would diagnose people with high frequency hearing loss as like presbycusis, which basically is a diagnosis, but presby is old age. So it's not, it's probably should be renamed. But the same guy that did that study, Rosen and his colleagues, went into Finland and actually took 2 mental hospitals where they had about 150 people each, and they put one hospital on, they took all the saturated fats out of their diet, and they rechecked their hearing 5 years later, and their hearing had actually improved. The hospital where they didn't intervene, it had actually gotten worse. So the improvement over the worsening was significant. So saturated fats, which you remember get converted to your cholesterol levels, has a lot to do with arterial health. So avoiding saturated fats. And if you take the animal products out of your life, you've got pretty much all the saturated fats out. However, unless you fall into the coconut oil trap, you know, coconut oil, palm oil, and things like that, which have 90% saturated fat in it, actually butter oil is 50%. So you've got to avoid the tropical oils as well, and I think we talked about that. So that's hearing. Any questions on hearing? For those of you who can hear me?
I started losing my hearing in my early 40s.
Yeah.
And my mother also, so is there a hereditary component?
Yeah, I think there's a hereditary tendency, and we'll talk a little bit about that. We'll see Dr. Campbell's, Colin Campbell's quote. He likes to say that nutrition loads the gun. I mean, genes load the gun and nutrition fires it. So it's probably the genetic tendency is there. My wife suffers the same thing, and her mother had hearing loss problems too. So let's go on to vision. If you look globally, cataracts, uncorrected refractory error, and glaucoma are the 3 leading causes of blindness or vision problems in the world. But in the United States, most people can get their cataracts fixed pretty easily, and you can get glasses pretty easily. So then the ones that rise to the top are diabetic retinopathy, followed by glaucoma and macular degeneration. And we've covered diabetes, remember, back in the first class. And actually, Walter Kipner published a couple of case studies in postgraduate medicine in the late 50s that showed reversal of diabetic retinopathy by nutrition. Now, I've talked to a couple of my ophthalmology colleagues about that, and their take is he just got lucky, or he was dealing with cases. They said, you can't cure that stuff, which is a typical response I get from a lot of my colleagues when I bring some of this stuff up. The people who reverse, they don't really care why they reverse. They're just glad they can see. But glaucoma, so for the diabetes, remember it's the fat in the diet and fat on your body that is responsible for your insulin resistance. Glaucoma seems to be related to some of the antioxidants in foods. And we know of 2, zeaxanthin and lutein, and those are where you find them, mainly in greens and some of the yellow vegetables. As you're going to see in a minute, the antioxidants are very complicated. There are lots of them. There are over 10,000 that we know of. And for macular degeneration, it looks like the anthocyanins, or blueberries and goji berries, or the blue type vegetables, seem to be helpful. Now, here again, you go to your doctor, they may give you tell you to take a supplement, but remember we talked about the difference between isolated supplements and getting things in the whole food process. So you want to eat for arterial health, and you want to seem to protect your eyes from UV light. It seems like the UV light has something to say, because if you take the lenses out of people, it increases their risk of retinal or macular degeneration problems. This isn't surprising since your lens is concentrating light onto the back of the retina. So that's vision loss. So these are your phytochemicals, for those of you who are into and you can see that some of these things are the carotenoids, which we talked about with the lutein and the zeaxanthin, and the other ones are down here in the flavanols. But there are over 10,000 of these. So trying to figure out which one is affecting it is really sort of it's like the myth of Sisyphus. The guy used to roll the rock up the hill and it would just come down again. So at any rate, they're in and they're out. There we go. We're back again live. Thanks, guys. So let's talk about cancer. And we'll go through cancer. It'll take a little longer, but then we'll take a break before we go into functional fitness. It's a growing and common issue. We've got, back in 1997, they said by 2020 it would grow by about 50%. There were 1 million people diagnosed in 1997. They underestimated it. It's about 1.75 million people were diagnosed last year, and about 1,700 people die a day from cancer. Unfortunately, in our age group, you probably know some of those people. About a third of the females will one day have cancer, and half the males. Actually, if you live to be Lee's age, which I'm working on, by the way, I'm only 72, as you'll see, Lee has a 100% chance of having prostate cancer. Unless he wants to voluntarily tell the class he gave up his testicles at age 40. I don't think he would volunteer that information even if we asked him to. But it's a male hormone-mediated disorder. And so the question is not for me at 72. I know at 90 I'm going to have a 100% chance of having prostate cancer. It's a question of whether it's localized or spreading. I mean, if it bothers me at 140, I don't care. So,
No, you're right.
yeah, I'd like, if I was around at 140, you're right, I would care, but I don't think I'm going to be here there. So if you look at the cancer rates, these two, prostate cancer and breast cancer, which you hear a lot about, you can see the rates and where they've gone over the last 20 years. So cancer, just to put this in sort of a simplistic concept, we could get into each of the diagnoses, and we'll talk a little bit about some of them, but I'm going to try and keep it broad-based so you have the concept so you can go find out whatever cancer, because there's lots of cancers. We could go down the top 10 cancers, but that may not even answer your questions. But it typically starts with one cell. The doubling rate ranges from 35 to 1,000 days. It has to grow to about 1 billion cells before it's detectable. The fastest type of cancer we've ever seen was post-Hiroshima, which basically says if you irradiate a large population with radiation, you're going to get leukemia in 18 months. We know that. Thyroid cancer was close to it, but I think leukemia was the fastest. The slowest is up to 150 years. So it's just a question of doubling. The incidence of breast cancer in women at age 40 is 33%. As part of a follow-up, I'm going to send out the Gottlieb, it's the Cochrane breast cancer leaflet, which is an 18-page leaflet that you ought to read before you get a mammogram, basically, before you decide to do that. About 33% of women at age 40 have breast cancer. About a third of those will get cured by your body. They'll never progress. Prostate cancer, as I said, is age dependent. Here's Lee up here, over 90%, over age 90, right? He said 100%.
I got it.
You got it, okay. I'm sure I'll have it. At 70, I'm up to about 70%. But you can see men going between 60 and 90. It just keeps going up, which brings up some real issues about screening for it and treating it, which is difficult for us to wrestle with because we're used to telling people if they got something, we got to get it out real quick. You got to remember, these things have been around for years and years and years usually. So if you look at breast cancer, this slide, courtesy of John McDougall, cancer, and it can be spreading when it's very small, and it's not detectable until it's about 8 years into the disease with mammography. The study we haven't done yet is if we let it go from mammogram detection to palpation detection, and then we treat it at that point, if the treatment would be any less effective than it was detected by a mammogram. We don't know that information. That's why when you read the Cochrane breast cancer leaflet, you will see that we probably, using mammography, kill 7 women for every 1 woman we might save. And the reason we kill them isn't because of the breast cancer, it's because if you diagnose a cancer inappropriately or treat something that doesn't need treatment and you irradiate people, it increases their cardiovascular risk from their heart with the radiation. So they die of cancer, they die of cardiovascular, like a myocardial infarction, but they don't die of breast cancer. So you could chalk that up to the medical profession one way or the other, depending on which column you put it in. On the column of we served the breast cancer, that is true. We killed them with radiation, that is also true.
Is that the radiation from the mammogram or the radiation?
The radiation from the treatment. If you take women over a 10-year period and do mammography on them every 2 years, 25% of the women in that population will have a false positive, which means something will be seen, they will go get a breast biopsy, it'll be negative, and then they'll go back to life, but then they'll be scared and be into the whole process again. I think when you read the Cochrane thing, what you'll take away is if you're a few weeks late getting your mammography, it's probably not necessarily that critical. So if you look at, unfortunately, Michael Greger's great talk on stopping cancer at all stages has disappeared into the, thanks guys, has disappeared into the ether somewhere. He got back to me, he couldn't find it. But the concept I'm using is from his talk, and basically you've got a cell that is exposed to a carcinogen. Obviously, if you're not exposed to carcinogens, you're going to be less likely to have cancer. Once it's exposed, you get a mutation that can then initiate into forming a cancer cell. Your body can tend to block this at this point by some, we're just starting to figure out with the epigenome about B12 and folate and some of the repair mechanisms that the body does to repair it, because we're probably always coming up with cancer cells all along anyway, we just cure them. And then finally, once your cancer is established, there are things that can promote or slow the growth. So we're going to concentrate on the first and the fourth today. So here again, I mentioned this I think earlier, dioxins are the most carcinogenic substance known to man or woman. It's a product of burning plastics. The safe level is less than 120 femtograms per day. That's the safe level, recommended FDA safe level. There's 49,000 in a scoop of Haagen-Dazs ice cream and 95,000 in a slice
Well,
of it.
that's just awful.
Yeah.
What's a
Haagen-Dazs?
femtogram?
A femtogram is a quadrillionth of a gram.
Oh,
Okay.
Very small amount. This is the stuff by another name, you can call it Agent Orange. We littered this stuff all over Southeast Asia during the Vietnam War. Yes?
What is the source of the dioxin in the ice cream and pizza?
What happens is plastics gets burned, it gets into the atmosphere, it gets on grasses and feed that get into the animal chain, and because the animals have fat cells, this stuff is fat soluble, so it's taken up by the body, and the higher up the food chain you go, the more of this stuff you get. You got to remember that they take cattle, and when they sell the meat, they take what's left over and grind it up and feed it back to the cattle. So they're just getting stuff put it back into the food. They don't grind up the brain and the spinal cord because of the mad cow problem we talked about last week. So that's the source. And backyard barrel burning is a big issue too. People burn plastics all the time. So that's the ultimate source. Now, if this stuff got into the body and out of the body very quickly, it wouldn't be a problem. But the trouble is the half-life is 1 to 7 years. We don't even know what the true half-life is because the only half-life studies have been done on people with industrial exposures, high amounts. So I've been eating nothing but plants for about 13 years now, which means if it's 7 years, my dioxin load is down to 25% of what it was when I was 58. So that's dioxin. Now, we don't, if you look at the other PCBs, the polychlorinated biophenics, sort of pesticides and plasticizers and things like that, you add them all together, you actually, the highest source of this stuff is freshwater fish, followed by butter and cheese and hot dogs and bologna. But we don't eat a lot of fish in this country. So the actual consumption is mainly in beef, dairy, chicken, pork, fish, and I'm still getting a little bit down here with air and water because there's a little bit of air and water. And if you can remember this backslide here, the vegan diet does have a little bit in it, but it lowers your rate even lower than milk. So that's the dioxins. There are other environmental factors besides dioxins. Your arsenic. Arsenic can lead to cancer. We'll wait and see if it comes back. It seems to jump in and jump out. So much for the AV people, right?
again.
There we go. Benzene leads to cancer, and the reason I don't drink sodas is because benzene is in sodas. It's actually a product of the ascorbic acid, which is vitamin C, and benzoic acid, which is a preservative. And they put them in all sodas. But over 67% of sodas in this country contain benzene, and over 30% don't meet the federal safe intake levels of benzene for humans. It probably just depends on how long the sodas have been sitting around on the shelf. It's not a particular brand thing or anything. Pesticides cause cancer. They're the PCBs we talked about, the leading source of meat, fish, and dairy. Nitrosamines are the leading source, and their leading source is processed meats, bacon, and hot dogs. This Wednesday, PCRM is filing a lawsuit against Gavin Newsom and the people down the chain who have dragged their feet for 5 years in putting processed meats, labeling it a class 1 carcinogen. That'll be a small step in the right direction. I'm one of 2 healthcare professionals named on that bill. So if you see my name floating around the press, or I'm supposed to be interviewed next week possibly by the Sacramento people, you'll know what's up. Yes?
I mentioned that benzene is considered a sufficient carcinogen is regulated in the capitals.
Oh, yeah, and actually,
That's one of the I think absolutely not the limits. Gasoline, that's been true for.
yeah, actually, they approached Coca-Cola with the fact that their product contained benzene, and their response was, yeah, but it has less benzene than cigarette smoke or car exhaust. So Coca-Cola is really looking out for your health there.
And then there will be a resource for it. It's serious.
Yeah, yeah, well, they should, because here again, it was one of the first cancer-causing agents that were identified. There's a lot of stuff out there in the environment. Heterocyclic amines are grilled meats, whether they're grilled, fried, or boiled, you get heterocyclic amines. Bye-bye slides. Just when you thought things were safe. There we go, we're back. So, okay, so let's move on from carcinogens to promotion. Prostate cancer, if you're a male and you get a PSA or prostate-specific antigen, which is a chemical that is produced by the prostate, more so by cancer-causing agents, less so than cancer cells, produce twice as much as normal prostate cells. So this stuff's normal floating around in my bloodstream, but they took control over a 6-month period and they noticed that if you went on a plant diet, that your doubling rate went up 10 times. So your PSA doubles every 12 months on average, or about 11 months if you're eating correctly. The other study was even more impressive, where they did a biopsy, a baseline in 3 months of 30 patients with low-grade prostate cancer. They put them on a plant diet for 3 months, and they rechecked their biopsy, and they had downregulated. They turned off their cancer genes, their protein replication genes. So by changing your diet, it changed your genetic expression, which is really kind of weird when you think about it, but it has a lot of implications. And they did actually some cancer survival studies where the macrobiotic diet seemed to double the survival rate, double and triple depending on the study. And if you look at dripping the serum from the bloodstream onto cancer cells in petri dishes, the vegan diets or the plant-based diet were more inhibitory than the control diets. Breast cancer is usually a estrogen-mediated phenomenon. We found that, unfortunately, out the hard way when we were passing out estrogens like cancer to women who were postmenopausal in the 1990s, and then the large study came out that showed, yes, the good news is we're helping with hot flashes and vaginal dryness, and, you know, the bad news is we were increasing stroke risk, heart attack risk, and also breast cancer risk. So we really stopped prescribing estrogens very quickly. It's normally produced by fat cells, by the way, so women who are over fat tend to have higher incidences of breast cancer and endometrial cancer, which are both estrogen-mediated cancers for the most part. And there are reasons behind that. So if you look at the actual food situations, dairy is strongly associated with prostate cancer, alcohol with a lot of GI problems, as well as breast and pancreas, colon and rectum are processed meats, grilled, fried, and boiled meats, here again, breast, prostate, kidney, pancreas, colon, and rectum. The interesting thing about soy, everybody knows about phytoestrogens in soy, right? If women take soy after they have a breast cancer diagnosis, they have less recurrence. If you give 2 servings of soy to adolescent girls and pre-adolescent girls, it reduces their risk of breast cancer in their lifetime by 25%, which is interesting. The problem is, a lot of the girls are getting exposed to dairy products, milk, and you got to remember they have changed the production. You know, the milking of the cows. Remember, those cows that are being milked are pregnant. They last about 4 years, because you can imagine how long you'd live if you were being breastfed and pregnant at the same time on a continual basis. But for those women in the room who remember their pregnancy days, you are basically experiencing a very high level of your own estrogen in your bloodstream. So when they're milking these cows because they're pregnant, there's a lot of estrogen, natural estrogen, in the milk. And if you take a girl and give her 2 or 3 glasses of milk, you're increasing her estrogen exposure by about 10-fold. You're doing the same thing to the males too, by the way.
I have a question about the soy.
Yeah, soy question.
So isn't soy like real, one of those high GMO foods, don't they take that into consideration when they're?
Yeah, GMO food question with soy, that's a good question. The industry has locked out research on GMO foods. So one of the things you'll see recommended as we go through at the end of this, I recommend people go organic if they can. If they can't, that's fine. But if you're going to do soy or wheat, you probably ought to go make sure it's non-GMO. Because we don't know what GMO stuff does. We know the soy is good for you, but there's soy and then there's soy. And remember, even with wheat, they don't use a lot of the Roundup to actually control weeds with the wheat, but what they do is they spray it on the wheat a couple days before harvesting to increase the yield. Yes, ma'am.
What did you say was the amount of soy that these young girls were given?
2 servings.
Servings.
Not a lot. Yes,
I didn't
sir.
understand the PSA on the prostate. You said the plant-based diet doubles I didn't quite understand that.
Okay, so if you stop eating the standard American diet and you go on a whole plant diet, your doubling rate for your PSA in your blood is going to go from a year. So it'll go from, let's say, 4 to 8 in a year. It'll go to 4 to 8 in like 113 months, which is almost 10 years. So the question when guys come into me and say, I want a PSA, I say, sure, I'll give you a PSA. I mean, they're telling me not to. I get one anyway, and I say, okay, now we know where you're at. Give or take the air in the lab and stuff like that. Do you want it to double every year, or do you want it to double every 10 years? You can just sort of picture how fast you'll get into the urologist. They put you up in in stirrups, and they take a scope, and if you're lucky, they'll do that. If you're unlucky, they will also do prostate biopsies, which is like needle punches through your perineum into your prostate, which scars the prostate, of course. And as my good friend Milt Fredenberg says, never underestimate the likelihood of surgery to make things worse.
I'm just curious about the phytoestrogens in the soy. It says during use to reduce breast as well as, doesn't that cause them the young person, you give them soy to develop earlier?
No, the soy doesn't do that, but the dairy does. Well, we don't really know why people are why people are going through puberty early. We know it must be dietary because our great-great-grandmothers back in the early 1800s went through puberty at the average age of 17.
Right.
It's less than that now. And we don't know, we know that it's animal protein or dairy or just being overweight. Remember back in the 60s, they used to make fun of the fat kids. Now all the fat kids make fun of the skinny kids. So we don't know the answer to that question, but it's a good question. The phytoestrogens seem to be different than the actual estrogens that are made by men, by women. And men make estrogens too. I mean, I have estrogens running around my body.
Was that among those who already had an expressed prostate cancer diagnosis, or was
No,
that
just general
so.
population.
Because doubling every year, that's the old checkerboard problem. You're dead quick.
Right. Yeah. And so, most of the people who get diagnosed with prostate cancer don't get told any of this information. Yes, ma'am.
So I'm confused about soy because
Good.
I hear so much comment.
Yep. Welcome to the toxic.
What is the recommendation that you say for postmenopausal women for soy in their diet?
Well, that's a different situation. I mean, I don't think there are any recommendations for soy in postmenopausal women. You want to control your hot flashes naturally, you might want to start taking a tablespoon of flaxseed a day and titrate it up to 3 tablespoons. Other than loose stools, it doesn't seem to have a lot of side effects to it, but it does control hot flashes better than a lot of the over-the-counter stuff, and certainly better. But here again, that's the clinical diagnosis. So all I'm saying is if you've had breast cancer, even if it's estrogen positive receptor, soy reduces recurrence. In pre-adolescent women who don't have breast cancer, you give them soy, they're less likely to have breast cancer in their lifetime. That's all we know scientifically at this point. And if you go to nutritionfacts.org and look up soy, you can get into some of those studies and stuff like that. Yes, ma'am.
Can you talk to the issue with soy and thyroid dysfunction? I think I've heard some of
Right.
that.
Yeah, there's soy. You have some compounds like broccoli and some of the cruciferous
Right.
that interfere a little bit with soy, but I mean with the thyroid functions. But it's clinically not significant.
Okay.
And sometimes if you're trying to fine-tune the TSH with the thyroid levels, you might have to make a small adjustment, but that's fairly easy to do.
Okay.
So that isn't you know, here again, it might mess up your thyroid a little bit, but you're also preventing cancers and a lot of other good things by eating that way. So you've sort of got to balance the whole picture.
So if you're on soy medication, you can't take the soy then? You can use soy?
If you're on what?
If you're on thyroid medication?
Yes, you can do the
can.
soy, yeah. Yes, ma'am.
Do you know anything about if gluten affects risks for cancer at all?
I don't think it does. Gluten, the question is about gluten affecting cancer, and I don't think it does. However, you've got GMO and non-GMO gluten. I don't know if I mentioned the gluten situation, but the celiac and the autoimmune is 1 in 130 on average in the country. But about 2 to 4% of people have an intolerance to wheat, which means they don't feel good, or they have loose stools, or it doesn't agree with them for whatever reason. They don't have celiac, they don't have full-blown autoimmune disorder. It's just that there's a difference between allergy, a disease, and intolerance. Me and walnuts don't get along. I just avoid them. I don't know why. So,
You're spoken about doubling times of PSA.
yeah.
Is PSA notoriously
You're right.
accurate?
It's accurate probably at the time it's taken, but there's variation over time. I had one guy I was following PSAs, he'd been biopsied and they'd all been negative, and his PSAs were running about 17. For those people in the room that know, that's pretty high. So the urologist told me just bring him in every 6 months, check his prostate digitally, and recheck his PSA. So he came back in and I rechecked it and it was like 28.
Wow.
So off he went, negative biopsy, back he came, And we went through this for a while, and he eventually died of pulmonary embolism. So it wasn't the prostate cancer that got him, but you're right, there is variability in that. And the whole thing, it hasn't been studied all that well. We take these blood tests and we take these values as if they're givens. And anymore, as a practicing clinician, this is my last month with a license, I'm not even sure what I would do with a lot of this information. I mean, even information that is considered gold standard, like cholesterols of 150. I mean, there are people with total cholesterols above 150. If they're eating right and they're active, I'm worried about their cholesterol. I'm certainly not going to give them a statin to deal with it because that study quite hasn't been done. I mean, I'm not even sure if I would be prescribing statins for women because we don't have a lot of studies in women on statins. Women in the world know this is not a fair world.
looking at doubling time, that's a very short doubling time. But could we say about 5 years if you increase by a factor of 32?
Right, right. And that's probably not true, but they were just looking at them over a 6-month period. And there's inaccuracies in the measure and stuff like that. So I don't know. All I'm saying is that one study leads people to think that their PSA will go up less if they're eating correctly, which not only has implications for prostate cancer, but might have implications for benign prostatic hypertrophy, which is just the prostate getting bigger and guys not being able to pee over fences like they used to be when they or getting in the line at the ball station with everybody behind you at the urinal saying, why is that guy up front taking so long, you know? But that's a problem on the other side. I know you guys don't have as many toilets as you need. But when we did the Rancho Cordova facility, we actually tried to do something about that discrepancy, but we were told that the male and female bathrooms had to be back to back, and with the plumbing, it had to go in each way. It made it cheaper. So the reason there are the same number of holes on both sides for the restrooms has a lot to do with cost and not a lot to do with physiology. They've done a study that shows that cancer is not related to fats in the diet. It's less fats. So the fats aren't the problem. Couple good studies on that. This went away. We'll wait for it to come back before we go on. There we go. Now, various effects of those phytonutrients in vegetables, you can actually go on the Nutrition Facts website, and what's interesting is everybody knows about tomatoes and prostates for some reason. It's sort of like bananas and potassium. But the most inhibition of cancer cells in petri dishes were the allium family. That's the garlic and onions and things like that. The most common consumed vegetables in the U.S., potatoes, tomatoes, carrots, and leaf lettuce, have only a very mild effect on cancer cells, various types of cancer cells in petri dishes, in vitro. So there are variable effects, like radishes have a good effect on stomach and breast cancer, but little on the other tumor lines. And you can actually go into nutritionfacts.org and sort of figure out what those are if you're interested in a specific type of cancer. And the study was done in food chemistry by Boivin and his colleagues and published in 2009. But they looked at basically the extracts of 34 vegetables on 8 different tumor lines: pancreas, breast, prostate, stomach, lung, kidney, glioblastoma, and medulloblastoma. The last 2 are cancers of the brain. So basically, just summarizing cancer before our break, genetics loads the gun, diet fires it. Conventional therapy is important because if you've got a big load of cancer cells going along, you want to try and reduce that before you intervene to try and get on top of it. The best resources I've found for cancer, there is no good single resource, are the Moss reports. Ralph Moss puts out these 400-page tomes that he sells for like $300 or $400, which is by each specific cancer. And there are very few cancers he hasn't done one on. I've only seen one. I've seen the colon cancer report. One of my colleagues in town, who's a Food for Life instructor, her husband was diagnosed with colon cancer. They got a Moss report, and she was nice enough to send me the PDF file. Keith Block, who I mentioned maybe before, wrote a book called Life Over Cancer. He was the founder of Integrative Cancer Treatment. He's a practicing oncologist in Skokie, Illinois. Terrible public speaker. I heard him speak at a McDougall Advanced Study Weekend and met him. It made him look good, though, because he brought his wife, who was the speaker behind him, and she was even a worse speaker than he was. But he's a practicing clinician who actually uses integrative stuff like nutrition. And I know a couple of colleagues. I was supposed to have lunch last week with one guy, but who's used him. I wanted to find out how he was doing, because I think he was diagnosed with a lymphoma. But unfortunately, one of his best friends killed himself, and he was going to lunch with that guy. He wanted, so I backed out, and we're going to have lunch later in the month. But for Keith Block, it's about $1,000. I think you get a 1-hour consultation. You send him your medical records, and you get a time with him and also time with his nutritionist, and they'll tell you. So those are the only 2 resources. I keep trying to tell Michael Greger that he needs to do, like Eating to Starve Cancer or something as a book coming out, which would be probably a pretty good seller, I would think. But I think he's leaning toward doing something on aging, which seems to have a lot of press these days. So, key concepts: you want to avoid cancer-causing chemicals. You want to maximize plants, the phytonutrients in plants. Animal protein seems to be associated it's like a fertilizer for cancer cells. My dentist for years, Doug McCreary, who's now retired up in Oregon, was diagnosed with pancreatic cancer about 2 years after he stopped practice, and he went up to Seattle, where they have a very good program for pancreatic cancer, very much quality improvement oriented. And he was reading the China study book in the waiting room, and he went in and talked to the oncologist, and he said, well, what's this stuff about animal protein? The oncologist says, well, it's just a fertilizer for cancer cells, stop it. Doug is alive 12 years later, living up in Oregon, second wife, doing vegetables and organic. Yeah, so maybe there was a wife, huh? Treatment up in Oregon. But anyway, he's doing fine. For pancreatic cancer, that's unbelievable, because the longest I ever had a patient live was like a year and a half. It's a pretty dismal disorder. It's associated with obesity and alcohol consumption for the most part. Yes, sir?
I just remember the headline. I never read the story, but when President Carter had cancer, then I don't know how much time when he was cancer-free. Do you know much about?
I don't know much about Jimmy Carter's cancer. It's brain cancer. I don't know if it's metastatic or it's primary. His brother, who was a heavy beer drinker, died of pancreatic cancer. Of course, I think Jimmy has a little bit of faith going on, and in his life, he's a Sunday school teacher, and also he's involved in some pretty amazing, Habitats for Humanity, international election boards. I think if you look back over the arc of our lives and you look at presidents and what they did after they got out, Carter's got to be pretty impressive with what he has done.
But he did do something though, I read that, something to do with the immunity. He went, they did some study or something, and now it's coming back to me. Something to do with the immune system.
Yeah, they're using the immune system. Here again,
Yeah.
your body's fighting off cancer cells and killing them off by your own immune system. So the melanoma type cancers were the first ones where we actually take your cells, check the actual protein receptors on the site, and we turn it into an injection, which then we give back to the patients to try and stimulate their immune system to fight off the cancer. So they may have done some immunotherapy for him. I don't know what his primary diagnosis is, but my guess he has access to pretty good health care. That would be my guess. And I think the world's better off for it for the most part. He's out there probably hammering nails into some 2x4s in some small community right now with his wife Rosalind, who's also part of that team, who's very important. So the phytonutrients, all you got to do is when you're shopping for vegetables, just get a variety of colors, okay? You can see what, you know, the greens, the yellow, the oranges, the reds, and the purples. They all have different types of phytonutrients. They got thousands of them. We don't know much about them. This is a sense of the reductionistic science not being able to explain what we should be doing very well because it's such a complex system. So any questions on cancer before we take a break? So, sort of an overview. Yes, ma'am.
Has prostate cancer become so commonplace that the doctor wouldn't tell a man about it?
Well, it's certainly commonplace. I don't know of any physician who would not tell the patient if they were diagnosed with that. Here again, I didn't diagnose people with cancer as a primary care doc. I just checked PSAs and sent them on to people that had instruments like needles that actually jabbed into the prostate and brought out tissue that they looked at under a microscope and made the diagnosis. All I know is, besides the assumptions for the class, which is nobody gets out alive, everybody does 24 hours a day, and we're experimental one, my profession is fairly simple. We need an accurate diagnosis first. You need to know what's going on. Two, then you want to sort of look around to see if you avoid over-treatment and appropriate treatment. But if you don't have a diagnosis, you know, so I think most people, you know, like I would always tell people honestly what they had. I mean, if they came in and they were worried about, they were having some problem in their lungs and they had a nodule, might be breast cancer, I would tell them what they had that I could tell them, and then we would refer them to people who could get tissue. I will tell you that thyroid cancer is in a different league, and I didn't get into it, but I'll mention it briefly. The mortality rate for, there are about 3 or 4 different types of thyroid cancer, and the mortality rate has been pretty low for the last 30 years, but the diagnosis of it has gone way up because we've been finding a lot of cancers in the thyroid and treating them, but it hasn't changed it because those are cancers that probably shouldn't be treated. There's a radiologist that I heard speak at McDougall, who's a radiologist with the Oregon Health and Science Centers up in Portland. When they do lung CT scans, they actually catch the thyroid. And you often see on reports that coming back to me like, CT of the chest looks good, nodule and thyroid. So I'd bring the people in, I'd check them for the nodule, and then I'd send them on to endocrinology who would do a biopsy. He doesn't even report the nodules. So that's an example of a gutsy clinician who, looking at the whole data, even though most of his colleagues are saying reporting a nodule just to cover their butts and get it out of their office, knows what's going to happen to those people and knows it's not going to be helpful. He might call the primary care doc and say, you know, on the side and say there's a nodule, you might want to check them clinically. Just keep an eye on it, which I think would be a good idea. Because these small cancers we find on these sophisticated tests, whether they're CT scans or MRIs, sometimes we get into treating things that we shouldn't treat. Not to say that the scans aren't helpful, because here again, I'm one of those, as an engineer, I like getting information. You know, the difference is between data and information. Get this data, you want to turn it into clinically useful information. First, do no harm. So, good question. Yes, Art.
So all this data gets interesting, but it gets confusing too.
Of course.
And you know, you try to figure out for yourself what's the strategy and what does it mean. For example, I just had a lot of PSA problems, all up and down, and of course, periodically, safely, you have, I want to say autopsy, it's not, I don't die, but they, you have to go in and have a biopsy. Very unpleasant. And everything's okay, come back, no signs. Well then, I have 3 friends in the last year. One in his mid-60s, one in his mid-70s, and one in his mid-80s. And the one in his mid-80s, I with my father, they said, yeah, you have something there, but don't worry about it, right? Dad lived to 92, and you never worried about it. He had another martini and went on. That's how my father lived. But this man is a retired physician. I sometimes wonder if that's why he's sort of getting the treatment. He goes in and he takes some sort of a therapy of hormone therapy or something like that, and they told him, look, this was an aggressive, type of prostate cancer. And the same thing with the individual at 65. Now, how do they make that distinction? Where in my case, they go on, you're just fine. These 2 other people, and you wonder, is there data that
There's actually something called the Gleason number. It's
What?
after a Gleason number, which is
Okay.
actually after a pathologist Gleason, not Jackie Gleason. The great one, right? For those people that remember the old Honeymooners show.
Yeah.
Unbelievable. Him and who's his sidekick?
Art
Ralph?
Randall.
Norton.
Norton.
That show was pretty funny.
Yeah.
But they have this Gleason number, and higher is more aggressive, or lower is more aggressive. It's been so long since I've looked at it or thought about it, I can't tell you. But by looking at the Gleason number, remember the prostate biopsy study?
Yeah.
They were less aggressive tumors. They were watching them anyway, based on the Gleason number, which basically they look at a microscope and they try and figure out, by looking at the microscope, how aggressive it is. So they tend to treat the more aggressive. And there was a time when we just treated all of them, but now the Gleason number is a factor as well. So that's a factor that we don't, those particular individuals you're talking about don't know, what their cases were, but it gets back to the individual. Everybody's an experimental one.
Right.
And clearly, regardless of what their Gleason numbers are, given what I know about cancer, I would push them away from dairy and animal protein, pretty quickly. But it's their choice, you just provide people with the information and they deal with it as best they can. So it is confusing.
It is confusing, and
Maybe I should add that as one of my assumptions, I guarantee that by the end of the course you'll be totally confused.
now
I thought you had it all figured out before you came here, but giving you a lot of
now
information.
is a physician, what's the standard of practice for a physician? Let's say in a medical institution like Kaiser or Sutter or whatever. Are they obligated to tell you if they feel in your prostate with digital examination that there's something there, or can they just think, well, you're 75 and whatever it is, you'll outlive you? So.
I always tend to, there is something called community standard, which is a standard that physicians are held to, common practice in the community. Now that could be anything from every doctor in the community is killing everybody, so that's community standard. To preventing and I asked a lawyer once that I happened to be talking to at the Advanced Study Weekend, because I'm one of those doctors that does not routinely order mammograms on women without having them read the Cochrane leaflet first, so they're making an informed choice. And if I was working with Permanente now, I would not want to be evaluated on how high my percentage of mammography went in women, which is what they do. So I asked him, I said, well, that's not community standard. Everybody's ordering mammograms every 2 years and they're pushing it because that's what the national standards are. But I've gone through quality training and I know that these expert consensus panels are more like political bodies. And what they come out with is sanitized versions. So when I asked him, I said, if I did this, am I putting myself liability at risk? He says, as long as you can stand on the science, you will be fine. You will be found not guilty as long as you're practicing evidence-based medicine. Of course, this is like getting audited by the IRS, you know, even though you come out and you're okay, it's not a process you want to go through, right? So there's also the issue of peer pressure. I mean, because when I went to work for Permanente, I'm an entry-level doc for 2 years, and then I get voted on for junior, and then I get voted on for senior. And if I don't get the votes in the group, I don't get in. And then even beyond that, for the people who are in, the senior physicians and the Permanente Medical Group who are shareholders of the for-profit group, they're being subjected to peers. Columbus Baptiste, who came up and talked at Linda, is a cardiologist in Southern California with the Permanente Medical Group, and he's all plant-based. And people come into him who have stable angina. He doesn't want to do any stents on them. He tells them about the nutrition. And I was able to talk to him because I drove him back and forth to the airport for the event. And I said, well, how many of your colleagues are doing this? And he said, none. So he's not putting himself at risk because he's the chief of the department. I told him I wouldn't go any higher than that in the organization if I were him, because that's...
What's the evidence basis for that? How solid is statistical evidence vis-a-vis the practice of putting stents in?
His evidence is more evidence-based than the others are, because they did a study with people with angina, stable angina, and they showed 90% of them in 3 weeks either eliminated their angina or got substantially better. So if I had a patient with stable angina, I would give them that option before I actually intervene. The other thing you have to understand about stents is they just get the big blockages out of there. It doesn't stabilize the arterial tree. And 60% of heart attacks occur in vessels that are less than 50% blocked. So the idea that you've got stable angina, we can fix it with a stent and you get blood past the blockage, but that doesn't necessarily mean you're not going to have a heart attack. The statins you're taking may do a job for that, but it may be the diet is more effective, but we don't know that.
See, that's what you don't know.
We don't know that. So
as a patient, you can say, I want a stent, and I also want to go on the vegan diet, right?
Sure. Oh, absolutely. But I would probably give the vegan diet a 2 or 3 week try, knowing that the blockages have been building up since I was a kid. And just because I'm not, the angina is rate limiting, but if it's stable. Now, if it's unstable, it's getting worse suddenly, where you're waking up at night with chest pain, then you're threatening a heart attack. That's an entirely different diagnosis. That's unstable angina. That's different. So here again, it gets back to the proper diagnosis. Now, could you treat unstable angina conservatively? It's possible. I've never seen a study on that. It would take some pretty big, to do that study, but you could do it in an informed basis. It would shake up the cardiology injury. But here again, 90% of stents and bypasses in this country are done with stable angina, which is pretty significant. So we're wasting billions of dollars and killing people, quite frankly.
Yeah.
So, we're backing off some of these procedures as the data comes out, but there's a lot more we could do to inform patients adequately about what their options were and be clear with them how confused we are about this. Yes, ma'am.
Has there been any studies regarding AFib and the vegan diet?
The only guy I've heard about AFib, and we sort of alluded to that in the second class, was the professor at University of Kentucky in Louisville, who's an expert on AFib, and he came and spoke at McDougall. And we don't have any good studies on AFib, although it's the most common arrhythmia. In populations that tend to eat a lot more plants, they don't get AFib. So my thinking is it may be some small vessel issues that's causing up the electrical problem. I don't know the answer to that.
Okay.
You'd think somebody would be studying this stuff, right? But instead we're ablating things and doing stuff, and he's backing away from the ablations because he thinks long term they're not necessarily as effective as, but people would prefer to just go in and get their oil changed, and get put on rat poison for the rest of their life. Or even though we have better drugs now, we don't have to monitor the blood. That was invented after I left. But here again, the bad news about those things is if you get a bleed, it's not reversible right away. So, yes, ma'am.
I wanted to put a plug into the movie that you told us about, A Game Changer.
Yeah.
If you're on the fence about vegan diet, I really thought that movie was great.
Yeah, the Game Changers, you know, Cameron, what's the guy that did Titanic?
James
James Cameron. He was sort of the person that put all that together. It's mainly designed, you know, the only problem I have with it about it's a sort of male high-performance athlete centric, but that's a certain market segment that needs to be shaken up a little bit. I wish they had put a little bit more in about women, I mean, in sexual function. I mean, the penis aspect of that is pretty interesting. I mean, the face on those three guys when they sat down, the guy plopped the model down and showed them how they were going to put this contraption on their penis at night. Their expressions were like, I think their eyeballs were going to fall out on the table. They were probably having buyer's remorse at that particular point. But it is an interesting movie because it does shake up a lot of paradigms about the protein issues and arterial health. And James Vogel, who's in that, I've never met him or heard him speak. I missed the time he came out to McDougal Advanced Study Weekend. I didn't go down. But he's the guy that invented the brachial artery check. The flow-mediated dilation study that you hear about, which has enabled us to look at the health of arteries very quickly after interventions. We never had that before. The only test you have as part of your blood test is a C-reactive protein, which is sort of a measure of inflammation in the body. And that's a good measure, along with homocysteine and some of those other things we check. But that's a good question, and I would recommend people see The Game Changers. I think it's available free on Netflix, maybe?
Yes,
Now,
it is.
I mean, we went to this. It was out in the theaters here for one day. I think we went up to Greenback or something and saw it, or we went over to Century and saw it. It was just in there for one day. And then, because there was, the investors in the film wanted their money out faster, but they wanted to, you know, make sure it had a broader exposure, and there was that going on. So I think what they did was they came up with a compromise once in the main theaters, and then they put it out on Netflix, you know, to get money that way. So, good question though, and a good movie. There's a lot of them out there. I guess it's time to take a break. We'll come back and hit functional fitness.
Yeah.
That's a quick question.
Silicate's gonna change my mind.
I'm confused about soy, it's good for you or bad?
I've already changed my blood pressure.
Soy. The only study that's ever shown that soy was, the question is about soy. Is it good for you or bad for you? The take-home message is it's good for you. It's a whole plant food. It's great for you. There did one study that showed it was connected with dementia. Unfortunately, the soy they used in the study was preserved by formaldehyde. So I think it probably had more to do with the formaldehyde than the actual soy that was
Where do they
causing
sell
it.
that?
That's the only study. So soy's good for you. The guys don't have to worry about, it's interesting that guys will avoid soy with phytoestrogens, which has never been shown to hurt you, but they'll drink 2 or 3 glasses of cow's milk, which is loaded with estrogen. Not to mention the IGF-1 and all the hormones that go into the cows and stuff like that.
So tofu would be considered,
Yep, tofu would be fine, would be fine. Here again, I would tend to stay away from the oils to fry them and things like that, but, you know, here again, remember the dose makes the poison. It's not small amounts of stuff that gets you in trouble. If you know, we're moving, we pretty much have avoided use of oil, except this weekend we're watching 4 grandkids. 3 grand dogs, well, actually 2 grand dogs and a grand puppy. All their parents are in the foothills celebrating my my youngest kid's 40th birthday. We get the grandkids, we don't get them all, we get 4 of them, and they're at that age where they're pretty well taking care of themselves. But you know, the devil's in the details here, and the dose makes the poison. So it's not, you know, we're making treats for them, right? So I make a chocolate cake and I use canola oil. Something I don't typically do. But the youngest, the 6-year-old, loves this chocolate cake. You know, so what are you going to do? We make some carrot raisin muffins, which they also like, that also has canola in it. So typically I avoid that sort of stuff. I water saute. But, you know, the grandkids are the grandkids, right? That's, you know, get a kick out of watching your kids parent, right? The reward for not killing your kids, so So, the thing is, you know, I may have mentioned that I played basketball in high school and college, but when I was in high school, they told us not to lift weights because it made us muscle bound. And then by the time I got to college, they were letting us lift in the off season. Because they realized stronger athletes had better performance. But if you lift in the off season, you don't lift during the season, you get weaker. So now they lift all year round, and the aerobic stuff came out. We'll talk about that briefly. Core, everybody's got into the core now. And we've learned some stuff about this over the years. So I just want to hit some of the high points to give you some working information about it. So you've got total body strength. Core we talked about last week when we went into the back. Cardiovascular fitness, balance, stability, flexibility. This is the sort of thing that I never worried about when I was younger. I used to go up in the mountains and ski, and ice and snow was a recreational activity. Now I consider it a slip and fall risk. I don't go anywhere near that stuff, right? So just say things change. What's the saying? Youth is wasted on the young, right? Okay, and some flexibility. So we'll just hit the high points. The benefits are functional fitness increases the ease of everyday life. It's low impact. Increases flexibility and coordination, improves balance and posture, helps with joint pain, and reduces your risk of injury. Because remember, it's not the falls that get you, it's the landings. This is the most depressing slide I've ever seen. The slide from, this is Jack Dixon's work from down in McDougall. This shows the muscle mass loss versus age. Now, I haven't found yet, although I can tell you from personal experience, I know I lost a lot of muscle mass, and since I'm going back to the gym, I'm gaining muscle back. I can tell you that. My wife can tell you that. So I don't know how reversible this is or how preventable it is. Nobody's done the study on that. There's no money in prevention, right? So, but sarcopenia, we mentioned with the obesity, remember, you can be normal weight, but if you're weak and can't function, you don't have any muscle on your body, you're at risk for some of this stuff, and you may be what's called normal weight obese or sarcopenic obese, which means you have a high % body fat but a low % muscles. So why is it uses muscle? Functional fitness uses muscle in the upper and lower body at the same time. It trains the muscles to work the way they do in everyday tasks, and it prepares you for everyday tasks. We'll give you an example. Just some of the general concepts. Movements basically occur at your joints. You never thought about it, but it's your joints that move. And this joint, of course, is where two or more bones come together. And there's a single joint movement or a compound joint movement. Single joint movements just move one joint. Compounds move more than one joint. And you're going to see the functional fitness has gone from single joint to multiple joint. So, in the old days, we used to do bicep curls, right? Now they do bicep curls and put the weight up here and they balance on one leg, so they're moving multiple joints at a time. So compound joint movements require your body to integrate the movements, just like you do in normal day life, whether that's walking or lying down. You're using multiple joints and your body's having to integrate all that stuff. Single is just isolation, and it really doesn't reflect what you're doing in everyday life. So examples of a single joint extension machine would be this, where you're just working the quadricep muscles. This is a compound joint body weight squat, where you're not using weights, but you're using your own body to work your quadriceps, but you're moving more than one joint. You're not just moving this joint, you're moving this joint and this joint. You see the difference between the compound and single? Yeah. So this is an example of the biceps curl, single joint movements, but this would be multiple joints. And you can see which one might be better for you.
Yeah.
By the way, this works just as well with 5-pound weights. I go to the gym, and I've been a gym rat all my life. I was an athlete. Never compare yourself to what other people are doing in the gym.
Right.
That's right. There's always people lifting more and lifting less. It amazes me. I wear my nutritionfacts.org shirt, and sometimes I get stopped and people ask me questions, and, but they're pushing supplements and shakes and all this sort of stuff there. It's just bizarre, So I never thought about this, but Jack has a nice slide that I thought I would share that shows that basically the joint-by-joint approach addresses each joint, but they alternate between the need for stability and mobility. Remember last week we talked that your core is actually stabilizing. Doesn't necessarily move, it just stabilizes the back. So it's interesting, you got stability, mobility to breathe, stability, mobility. They sort of alternate. Your body knows how to integrate all this. It's a complex system. So if you're here's the core strength. Remember all the different muscles we were talking about last time? Now, cardiovascular training, low intensity, steady state. This gets back to the person that coined the term aerobics, Ken Cooper of the Cooper Clinic in Dallas, Texas. I actually met Cooper. He tried to hire me to go to the Cooper Clinic, and I didn't. I said no. I was in Sacramento. Kaiser Permanente had a lot. I was in charge of preventive medicine. He was out doing a talk. He came by and tried to get me to go to Dallas. Would have changed my arc of my career, I'm sure, but this is important. 30 to 90 minutes at a time, not your maximum heart rate, but sort of like, you know, where you're not quite breathing. You know, you can do it, the cheap way to do it is your aerobic. If you start over breathing, get a shortness of breath, you've gone a little bit too high. But I'll tell you, this stuff is, see all the fancy machines up there, walking is a great exercise. Remember we talked, was one of the 4 key exercises that Stuart McGill, in the back mechanic author, says it's one of his core things, walking 30 minutes a day. It's cheap, doesn't require a lot of, you know, expensive equipment. But it's basically constant, unchanging speed. That's what low intensity, steady state cardio is. And Ken Cooper did a lot of studies on this back in the 70s. It takes a minimum of 12 minutes to start getting the training effect. It's associated with better performance in school and junior high school, and there are a lot of benefits to it. There are studies, however, that show people that do steady state for long periods of time, like marathon running, and some of the stuff I used to do with endurance bike riding at distance, people are more susceptible to colds after they finish events. So it may be that you can overdo this stuff. So moderation is probably a good way to start. And of course, if you've got any concerns about health, you want to check with your doctor before you do any of this stuff. They've also discovered that HIIT, high intensity interval training, they're always looking for, it's like the latest diet, right? You know, you move from core to, you know, Pilates to golfing to, anyway, this is basically intense, short interval, and then you sort of drop down. So it's repeated bouts, short duration, high intensity intervals followed by lower intensity recovery in an active sense. So if I was on the bike trail, I would go real hard for a minute, as hard as I could, and then I would just go back to my lower. And this has been shown to be useful. But I would caution people about this, because we don't want you to go into a high intensity state and have a heart attack or a stroke, right? I mean, this, I don't think people need this for the most part. It's just more for performance athletes. And, you know, like my 40-year-old who's got one of those Pelotons where he's in a class and stuff like that, and they jump you up and down all the time and stuff like that. It seems to be working for him, but he's 40, you know, and I'm 71. Of course, he's never beat me on the basketball court. Fortunately, I haven't played him since he was in high school. And he's never come close to beating me on the golf course, and he probably won't for another good 10 or 15 years either. So anyway, there are some home programs you can do that, you know, the thing that I've been impressed in, and I'm an athlete, so I get, you know, it's like my wife always says, well, you know how to get to do things. They just tell you how to do it and you do it over and over. Remember how people learn? They fall off the wagon, they have to be reinforced, they learn, they incorporate it. This is a 7-minute workout, just an example of what you can do at home. Jumping jacks, wall sits, push-ups, abdominal crunches, stand up, down, squatting, triceps dip. You know, none of this stuff requires a lot of fancy equipment. And when you think about it, this would be a good workout for muscle strength, and if you did it regularly, your pulse rate would probably get up for 7 minutes. You wouldn't get an aerobic training effect, but it would be healthy. However, when you get to be older, you've got mobility and flexibility. And the mobility is the ability of a joint to actively move through its intended range of motion. Flexibility is just its ability to temporarily stretch when it's needed. Now, I could never touch my toes except for a very limited period of my life. But there's stretching going on, and we used to stretch all the time before we would do active stuff. But now they have shown that static stretching, which is just holding before you exercise, actually increases risk rate. So they talk about dynamic stretching now, which is movement stretching, and then doing static stretching after exercise, after you're warmed up and stuff like that. So we have learned a little bit about this, but unfortunately, my experience, the musculoskeletal world is, they have a lot of silos. You know, you've got your yoga teachers, your Pilates teachers, and your Rolfers, and your physical therapists, and they're all sort of, they've all been trained and they're in a certain silo, but there are a few of them who are capable of tailoring it to your needs. Remember, you're in experiment one. You have to decide what you want to accomplish, set your goals, and focus on things one at a time. And as you start feeling healthier, my guess is we're going to need more orthopedic surgeons and podiatrists and people like that, because people, as they feel healthier, they get more active. When they get more active, they do dumb things. They fall off bikes and, you know, even crazier things. I've seen people over the age of 40 get on skateboards, which is a formula for disaster. You know, I mean, it's bad enough bicycles. I mean, there's only two types of cyclists, those that have fallen and those that are going to fall, right? I mean, I don't know. But balance is a key to all functional movement. It helps your posture, you know, just balance helps your postural equilibrium, your muscular balance, your joint dynamics, all of it. And it's important because it's more important when you're older than when you're younger, because this, you know, you're dealing with a lot of stuff. And just walking, running, biking, or swimming, you're requiring yourself to balance. That's why walking is such a good activity with good posture and arm swinging. It's a great activity. So you can actually work balance exercises into your everyday life, right? Stand on one leg when you're waiting in line at the theater, bank, or the grocery store. Stand on one leg while you're brushing your teeth. 1 minute on each leg. Not as easy as it sounds, by the way. At least not for me. Practice sitting down and getting up in a chair without using your hands. Practice walking heel to toe. People might look at you a little funny, you know. But if you're stopped by an officer of the law and they take a sobriety test, it might be useful to have a little practice. And obviously there are classes like Tai Chi and dance classes that combine all this stuff that are fun, right? We're talking about having fun. You know, I mean, there are fancy mechanisms you can get into like this, but there's so much stuff we do every day. Your body will adapt. Just move. And, you know, with some bands or some light weights at home, you can have a very nice program. You don't have to go to the gym, although there's a lot to be said for going to the gym. I view gyms now as an environmental control. If I'm at home, there's the desk, there's the presentations, there's the laundry, there's my wife's list, you know, there's all this stuff going on. If I go to the gym, I'm there, I'm doing it. So I basically, it's successful basically because I've been controlled by environment. I've changed it, right? So it's like if you're running around with a bunch of smokers and you can't quit smoking because of your friends, you might want to change your environment, right? There are some resources out there. This is one that Jack recommends, Dixon, fitnessblender.com, where you can have it. I haven't looked at this video, but he made the recommendation, just like the books, you know, the Go Kale Method and Stuart McGill's Back Mechanic book. So I throw it up there. I appreciate him sharing his slides, by the way. So remember, you're at experimental 1. So we got whole plant foods, functional fitness. We just added functional fitness to the fitness. B12, non-smoking, lean body weight, avoid the toxins. Here's rosemary. I thought we could, let's see if we can play rosemary here. I still haven't figured out how to get these things to play automatically. I can sometimes, but in this case I didn't. So let's see if we can get rosemary. She's one of the Berkeley Meals for Health people.
Like 190 over, 120. I mean, I was really in trouble, and I had to have a pacemaker. I had some heart problems. My blood work, my blood pressure today is very different. I went to my doctor, my cardiologist. My line blood pressure was 126 over 72. Standing up was 114 over 70. Now that's low for me. That's very low. And just changing to a plant-based diet. My blood pressure has come down. That's all I've done. First of all, I'm a diabetic, and my fasted blood sugar is 95. It's never been that low. It's normal. I have more energy than I have had in years. You know, you get to a point, you get to an age, you think, oh, wow. I'm just energized. I feel like, it's a term we use in our church, in a way my body's been born again. I really feel good.
She lost 42 pounds in 2 months. She was off statins, off all her medications. The cholesterol was still low after she was taken off the statins. I did that at the end of the second week because we checked these people back at the end of 2 weeks. We did their blood work. She was off her blood pressure medicines. Unfortunately, Rosemary did have an accident in her kitchen at home, and nobody knew about it. She lived by herself, and church members found her. She'd been down for 2 days. She was hospitalized, and she does fine, but it's one of those things, and we'll get into this next time, because remember, accidents are on one of our lists, and we got to get to the accident stuff. But Rosemary had a lot of interesting consequences of her change in diet, and did very well. I want to mention supplements, because I got some questions by email. Isolated supplements, vitamin A and E, have been shown to increase mortality. Beta-carotene increases mortality. These may be associated with Alzheimer's disease. You often find copper, zinc, and iron and aluminum in multiple vitamins. Vitamin D is toxic at high levels, but remember I said it's possible that taking 2,500 on average a day would be acceptable if you wanted to do that. I got a question on fish and fish oil. We can analyze the women's hair samples in this room, and your arsenic and mercury levels in your hair are correlated with how much fish you've eaten in the last 2 years. Haven't done the study in men yet. Most of the fish you can consume contain insecticides, and they have high in fat, saturated fat, and cholesterol. Fish oil has no effect on your inflammatory markers on your arterial tree. It's loaded with insecticides, PCBs, obesity-causing agents, and other industrial pollutants. You can go to nutritionfacts.org and just click on fish oil and get the skinny behind fish oil. I mentioned this before, but the vitamin C level in an apple is 5.7 milligrams, but the vitamin C effect is 1,500 milligrams. So there's a difference between taking apple juice with a little vitamin C added back to make it more like the apple and eating an apple. The difference between whole foods and processed foods. So the only supplements, most people get enough salt added, standard Morton salt and stuff like that, iodized salt, to make their iodine levels fine. You don't have to worry about this. I just got a call from a friend of mine who's been plant-based for a long time, who's got a swelling on his thyroid. It sounds like I gotta go see him in the next couple of days. But I emailed him to make sure his iodine level was okay, because he may be using no salt at all, and he may be taking a lot of the broccoli. I know he eats a lot of greens and stuff that have an effect on thyroid, so I'm gonna go check it. But here again, if he's got a swelling, he's probably gonna need to see a doctor and get an ultrasound. But his trick will be, once he gets the ultrasound, he might wanna just try the iodine supplement for a while and see if it changes that.
So if you're on Synthroid for thyroid,
Right.
do you still go ahead using the iodized salt?
Yeah, I think, it's very hard. I mean, I cook with a little more than salt, but remember those Himalayan sea salts? They don't have iodine added. So I typically use traditional iodine, Now, on the west and east coast, it's less of an issue because the vegetables and stuff that are grown on the coasts tend to have higher iodine levels than those done in the central part of the country, which is where the iodized salt recommendation came from, because like 40% or 30% of people in Colorado had goiters because people consuming food in the middle of the country. So that's what led to the iodized salt recommendation. So it may not be a problem here on the coast. But vitamin B12, we're talking 2,500 milligrams. I think I'm going to have to wait until the webinar back in May for nutritionfacts.org, where he's going to go over B12 and come up with the science. Yes, ma'am.
Is that supposed to be milligrams?
Yeah.
Micrograms.
Yeah. That's the unit commonly used. And cyanocobalamin has a longer half-life than methylcobalamin, which is they're equivalent as far as the amounts. I mean, they're equivalent. It's just that they have a little longer shelf life for the cyanocobalamin. Vitamin D, get it sunlight. It's a healthy way to get it. But if you want to take 2,000 or 3,000 a day, you're not going to get the toxic levels the studies have shown. Those are the only recommend. Now, next week we're going to start talking about the environments you live in. So here's a cartoon. We've got the carnivores here and the pandas, which eat nothing but bamboo, right? The language barrier hasn't been much of a problem so much as the whole vegan thing. I think I sent out the recommendation to Watchdog Lyles, how to get along without going along, and the willpower. I'll send out some recommendations for next month. There's one he does on a couple of others he does. One of them's kind of hard to find, I want to make sure you see. But your environment around you, the people around you, your family, your friends, you know, that whole thing, we're group animals, by the way. You know, back a long time ago, getting thrown out of the group was death. I mean, we needed to be in a group, we protected ourselves. We're getting to sleep next time. There are owls and doves. Have you noticed that? People that can stay up later and people that get up earlier? You notice that? This is not random, by the way. Most predators are around just a little bit after dusk and a little bit before daylight. So it's nice to have people in the group who are a little bit awake later and a little bit kind of a little earlier, so they don't get eaten, right? So you know, some of these things are built into our biology based on what has worked a long time ago. This is a long time before we invented the light bulb and messed up our circadian rhythms and stuff like that. So at any rate, so remember, they got the nutritionfacts.org website.
Did you send anything out last week?
No, I did not send anything out. And McDougal and PCRM, and that's any questions, and you can email me if you don't get them. Yes, ma'am.
Is the scientific 7-minute workout online?
Don't know the answer to that. Might be. Google it. If it doesn't, I can send I'll do a screenshot and send you an email. Yeah, it's here again, it's a little bit more intense. Jack Dixon has a recommended McDougal workout that I'm going to send out, which is just a home-based thing, which just requires some light weights and movement, basically. And I think that would be less rigorous than that. But here again, you've got to be careful when you start these things, and you've got to make sure you got position finished. Yes, ma'am?
Are we able to get this online yet?
Not yet. I haven't figured that out. I think probably what's happening is when I try and send this stuff out, the videos are too large to allow it to go out through my server. So what I'm going to try and do is take the videos out, which you aren't going to be able to see anyway, and see if I can send it. And if that doesn't work, I'll try breaking them up into halves and see if I can get them out that way. However, I do have all of them on my computer, and anybody that wants to bring in a flash drive, like one gentleman did last week, I don't mind transferring those presentations to your flash drive.
There might be a way you might talk to about the technology at Renaissance. They might be able to put it on their website somehow.
Well, it's going to be put on my website. What we're going to do is we're going to set up a YouTube channel and put them all on the YouTube channel so you can watch them. So it will be there, but that's why Sean's videotaping them. And nice to have support here. Yes, sir.
I did a little bit.
Yeah. Yeah.
I broke my ankle, I bought one pair and then I bought a skirt.
Right, so it may get out, for me, but you can't get it. Yeah, I don't know how Art did it. Art did it last.
What was that?
About sending out emails, or your slides, you sent them out last time.
Right.
You encounter any problems?
No. Did you get them?
Oh, I got them.
Yeah. Well, I mean, no one complained to me. Somebody, I had their email address incorrect, but other than that, that person.
On the other hand, this may be like, can everybody
But if you have video embedded in it, that's going to be a problem for a lot of people.
Right, so so what I'll do is I'll try and get the videos out and send them out.
Yeah.
And if people start getting a slew of these things, that's fine. But I mean, if you don't want to get them, you send me an email and I'll take you over. It's just easier for me to send them out to the whole class.
Yeah.
The YouTube programs would be under your name?
Would be. But it'll be linked to my website.
Yeah, okay.
Because I asked my web guy, who's going to redo my website, which hasn't been done in a couple of years, the best way to do that. And he said, set up a YouTube channel, put it on that, and then link for my website. Yeah. Thanks for asking. At any rate, we got forum coming up. Any other questions? See you guys next week. Congratulations for surviving the fifth. Okay.